Welcome to Owning the Hamilton, a guide of what to do when you can no longer own the Oxylog. When you hear that a piece of equipment is getting an upgrade, you naturally think of going from an iPhone 12 to an iPhone 16. Not a big deal, bigger camera, bigger battery. Same, really. But the Oxylog 3000 was made in 1999, so it's more like going from a Nokia 3310 to an iPhone 16 because 2G is being turned off. This is both good and bad, so let's unpack this. On one side, thanks to some Scott Weingart-inspired guidelines, you had a great mental model about both patients and the ventilation strategies they require that worked really well for a decade. Do you really have to change? On the flip side, the Oxylog is basically a bellows with some timers and alarms, while the T1 has 10 ventilation modes, is configurable, and has what some consider an automatic pilot setting, ASV, that Scott Weingart reckons is a good option if you don't know how to ventilate. But the safety sciences warn us that becoming reliant on automation may not be a wise strategy. Here's a case where all three pilots had no idea how to fly the plane when the autopilot had to be disengaged. So what do? Use the Hamilton as an Oxylog, which seems like a waste, or do you use the autopilot and forget how to ventilate? Well, that was a trick question. The answer is both. You need to know how to fly the plane manually. Keep your beloved mental model and don't de-skill. You need to know how to use the autopilot. You want to know that you can trust it in a crisis. And you need to practice rare but predictable nightmare scenarios using simulation, using more than one strategy. Whether it's reducing a shoulder or ventilating a patient, it's good to have a plan B because plan A doesn't always work. So, if you remember your Oxylog, you had two types of patients, thus two types of ventilation strategies. Obstructive, which were your CO2 retainers, and protective, which was everybody else. Both got 6 milliliters per kilogram, ideal body weight for simplicity's sake. For the protective strategy, where oxygenation was the problem, we'd use the ARDSNet PEEP FiO2 scale to achieve our desired saturations. For the obstructive strategy, where gas trapping was the main problem, we would slow the respiratory rate and increase inspiratory flow to avoid breath stacking. We would minimize PEEP and accept lower O2 sats and higher CO2 level. In both cases, if we had high pressure alarms, we'd do a plateau pressure to see if the problem was an upper or lower airways problem. We had similar strategies for pressure control ventilation because kids used to have uncuffed tubes, and non-invasive ventilation because whether adult or child, cuffed, uncuffed or masked, what we were trying to achieve was the same. The T1 has 3 configurable presets, which Stacey Turner from Western Health came up with the genius idea of setting to mimic the Oxylog mental model. The presets are SIMV plus protective, SIMV plus obstructive, NIV, which we'll talk about later. SIMV plus is pressure-regulated volume control, which is a combination of the old volume control and pressure-controlled ventilation, in that it hits the designated tidal volume you want, but uses pressure-controlled ventilation to do it. Just by punching in sex and height, it calculates the tidal volumes at 6 milliliters per kilogram of ideal body weight. It also determines a respiratory rate based on that which you have to tweak, according to whether you have a protective or obstructive strategy. We would have loved to have done that for you, but we weren't able to. The titration of PEEP and O2 remains the same as before. The other settings detailed here, that are grayed out and in italics, we've preset so the only ones you have to keep an eye on are the ones in black. For example, the I to E ratio, which needs to be manually titrated with every change in respiratory rate. The T1 doesn't give an accurate plateau pressure or driving pressure, but it does measure resistance and compliance. Both of these are obviously on a spectrum and the numbers can be hard to remember, so the T1 uses pictures to help you diagnose. The dynamic lung on the left shows restrictive lung disease, an ARDS-like pattern. You can see it has low resistance, as shown by a normal bronchial tree, and low compliance, as shown by the lung's inability to inflate normally. The treatment is as you'd expect, Seek and treat underlying causes, such as pneumothorax and abdominal distension, and decrease tidal volume and increase respiratory rate to maintain minute ventilation. The dynamic lung in the middle shows obstructive lung disease, like asthma or COPD. You can see it has high resistance, as shown by a red constricted bronchial tree, and high compliance, as shown by overinflated lungs. The treatment is as you'd expect. Seek and treat underlying asthma/COPD, and decrease respiratory rate so that you aren't gas trapping, and increase your I to E ratio to allow exhalation. The dynamic lung on the right shows a mixed obstructive and restrictive lung disease, as shown by high resistance, as pictured by a red constricted bronchial tree, and low compliance, as shown by the lung's inability to inflate normally. The treatment is as you'd expect. Specifically, if you have an asthmatic, COPD, with this picture who is gas trapping to the point of dropping their blood pressure, disconnect the ventilator and manually decompress the chest before reattaching. So far, so good. You've kept the Oxylog mental model that has served us well. Now, let's move on to ASV. ASV, or Adaptive Support Ventilation, is a proprietary ventilation mode invented by Hamilton for NASA astronauts when they intubate someone in space. It can be found under the Modes tab. It's what's called closed-circuit ventilation, so it does not function if there is a leak in the circuit. Unlike our PSIMV strategy, where we have a fixed tidal volume, here we have a fixed minute ventilation based on height and sex, where the ventilator determines the optimal tidal volume and respiratory rate depending on lung dynamics. All you have to do is dial in what percentage of predicted minute ventilation you want. That number is dependent on whether you are choosing a protective or obstructive lung strategy. The rest of your settings are the same as before. While this is different to what you have been doing before this point, this is the point. Your plan B can't be the same as your plan A. Unlike the whole video versus direct laryngoscope debate, you don't have to choose just one. You can start with your manual strategy on every patient, and once the patient is stable, switch to ASV just to see what it does different, because it will be different and you need to be ready for it. We've talked about the dynamic lung as a diagnostic tool, but here we're talking about the ASV graph, which is only available in ASV mode. The ASV graph is not only a diagnostic tool, but also tells you what the T1 is doing. The y-axis is tidal volume, the x-axis is respiratory rate. The curved white line is the minute volume which we set. As you can see, the relationship between tidal volume and respiratory rate isn't linear. The square is the safety window. With every breath, the T1 takes 200 measurements and does multiple calculations to determine where breath stacking, barotrauma, apnea, and dead space ventilation are likely to occur. The T1 won't ventilate outside that box. The green dot on the minute ventilation line is where the least energy expenditure occurs and what the T1 is aiming for. The yellow X is where the T1 is ventilating with its current breath, and you see it heading towards the green dot with each breath. The key concept here is that ASV is not fully autonomous ventilation, where you turn it on and turn your brain off. It is a team member that is telling you what it's doing via the ASV graph, but you still have to direct it using percentage minute ventilation, PEEP, and O2. The ASV graph can be used diagnostically. In a lung with a restrictive lung disease like ARDS, you can see the shape of the safety window shows you it will aim for small tidal volumes and a high respiratory rate. A lung with COPD will get you a larger tidal volume and a lower respiratory rate than you're used to. As we said, this is fine. Your plan B can't be the same as your plan A. And if it's a mixed picture, something the Oxylog couldn't handle as the obstructive and protective strategies aren't compatible, the T1 has a better chance of threading that needle. Look at the size of this safety window compared to the normal lung safety window. NIV is the third preset that we have for you. It's very similar to the Oxylog in that there's no automation of this mode, apart from it switching to its pressure control ventilation if the patient becomes apneic for more than 20 seconds. As always, decide what type of patient you have. If your patient has type 1 respiratory failure, titrate as per the ARDS-NET protocol. Here's a tip. If your patient is hypoxic despite supplemental O2 and has new chest X-ray changes, you're likely to need at least 10 of PEEP. 5 is homeopathic. The old adage of CPAP for APO and BiPAP for COPD is simplistic and wrong. Essentially, it's a case of asking, is this patient, regardless of the cause of their respiratory distress, generating enough minute ventilation to avoid CO2 retention? While the patient controls their own respiratory rate, we can augment the pressure support and thus their tidal volume. We should give enough pressure support to get a tidal volume that results in a non-met call respiratory rate. While blood gases are helpful, if you look at tidal volume and respiratory rate, you can titrate settings much faster. A couple of points on troubleshooting in NIV mode. The machine does half the job, the mask does the other half. If you are having trouble with a seal, please speak to your respiratory ward as they have many more masks than you do, and if the patient is on NIV at home, they know where in the medical record to look to find both the patient's mask and settings. NIV, or CPAP for obstructive sleep apnea, is a very different beast to NIV for respiratory failure. In sleep apnea, PEEP is used to splint open the upper airway, not the alveoli. Much more PEEP and a different mental model is needed. This is particularly so if you are doing procedural sedation in obese patients who might have sleep apnea. While ventilator-assisted pre-oxygenation, VARPOX, is a simple and useful concept, please ensure you have read up on it before trying it. A quick note on pediatric ventilation. The adult pediatric circuit works down to 10 kilograms, and the neonatal circuit works up to 15 kilograms or 4 years of age, so there is an overlap zone between 1 and 4 years of age where both work. The ventilation strategy is the same as adults, except that in neonatal mode, tidal volume and respiratory rate are determined by weight, not length. That said, you can estimate weight using a Broslow tape. ASV is not available. Troubleshooting in neonatal mode also mirrors what we do in adults. We've added Victoria's Paediatric Retrieval Service contact details here because they like to know about any intubated child as soon as possible to help with ventilation. NIV on the neonatal circuit is also similar to the adult settings. You're most likely to use this in bronchiolitis or in actual obligate nose-breathing neonates where nasal CPAP is recommended. The trickiest part of nasal CPAP is selecting a mask that fits. This QR code takes you to a video that will show you how. If this approach to ventilation appeals, the next steps are getting the Hamilton rep to help you configure the T1 as per these guidelines, attaching these guidelines to the T1, double-sided A5 and laminated. Learning a bit more about ASV. Look up ASV on emcrit.org. It's open access, as is the video at the bottom. Both will help you understand the theory and the evidence behind it. Loading the Hamilton app onto your iPad so you can get used to navigating the interface, but don't mistake mucking around on an iPad for simulation training. You need to run some actual sims. What you will need is the T1 with the attached guidelines, the SimMon app. Nothing will get you in the zone as the sound of dropping sats. It also shows you to shark fin end tidal traces for your obstructed patients. The SmartLung 2000. This is key because the 3 parameters you can modify on this test lung are compliance, resistance, and leak, which are the 3 things that T1 measures. Using the SmartLung 2000 will help create a new mental model of how both patients and ventilators work. It's a small investment if you consider the hundreds of staff that will use the T1 over the decades that you have it. The attached sims for the classic rare but predictable ventilation disasters you want to have practiced for before the real thing rolls in. Have a happy and safe flight.